Okay, so we're going to get started. Okay, so we of course going to be talking about constipation today. It's based on a course that I've completed from a pelvic health physiotherapist in South Africa. So we'll be talking about an overview of the different systems involved, how defecation occurs, the reflexes needed, your pelvic floor, what is the different types of constipation, and what is functional constipation, how do we treat it, what is my role as the therapist and other therapists in this, in helping you with your child that is having constipation issues, what are the next steps after this. I'm going to give you some tips for some toilet training, whether you've completed this already or it's something you're looking at doing with your child. And yeah, we can just give you some useful links and resources and then the references at the end. So with constipation, we kind of like to look at this iceberg in order to explain to you. So normally if a child comes to me, they'd be coming with their parents saying, you know, they're incontinent, they're having some leaks or some issues with poo leaking, they're wetting the bed, or they'll only poo in a nappy. But what we as therapists look at is all these other issues that could be causing this. So you're coming to us with the functional problem, and we come in and we're going, these are kind of the questions we'll be asking, you know, do they have frequent UTIs? How's the toilet set up? Are they avoiding going to the toilet? Have there been constipation issues in the past? Have they had medication for it? Or has it just corrected itself? Do they get the urge to go to the toilet? Do they speak about going to the toilet? Have they just changed schools? There's a lot of different things that we'll be asking if you were coming in for a consultation. So I just want to briefly go over the urinary system and the gastrointestinal system, just to have a better understanding when I'm talking about these systems. So the urinary system, of course, filters blood and creates the urine as a waste byproduct. It involves the kidneys, the renal pelvis, the ureters, the bladder, and the urethra. The micturition cycle is basically the cycle that creates the wee and allows us to get rid of these the waste products. So it's under sympathetic and parasympathetic control. Basically, your nervous system, you have to tell it, you know, it tells you that you need to wee, and you have a constant conscious decision whether you're going to wee or not wee. And it's complex, and it requires quite a bit of understanding and compliance from a child for them to understand what is going on with their little bodies and how can they, you know, go to the toilet and what do they need to understand in order to do so. So with going to the toilet, with regards to wees, with neonates, you're going every 1 to 2 hours. That's why at the beginning, when you have a little baba, they're going through so many nappies. And by 5 years of age, they should be continent both day and night with increasing bladder volumes. Your expected bladder capacity you can work out with the following way of doing it, and you should be going 4 to 7 times a day is normal, and that's with a complete empty. So not just your child going and doing like a little wee now and again, you want that full emptying of the bladder. Your gastrointestinal system is for your digestion, your absorption of nutrients, and of course that excretion of any byproducts and waste products in the form of poo. And it's also a protection mechanism against anything attacking the body. So in order for your child to poo, there are 4 phases that happen. So your colonic activity propels the contents that have come from the stomach into that small intestine, and then it goes into that large intestine. For adults, it can take 72 hours, and a child, it normally takes 57 hours. You get that pre-defecation phase, which is that awareness and that urge. So it should be felt in the rectum, so in your bum. And what we find is a lot of children that have issues with avoiding this first feeling is that they actually start feeling it in their stomach. So once you get that urge to defecate, normally felt in your bum, you get that expulsion phase, which is your conscious decision to defecate. So you've told your brain that you're going to the toilet and you will be defecating or excreting or pooing, lots of different words for it. You'll get an increase in your intrarectal pressure, and you get that relaxation of the pelvic floor, and everything comes out. And then you get the termination of defecation, which you sense that you've completely emptied, the straining ceases, your intra-abdominal pressure falls, and your postural reflex in the pelvic floor is reactivated. Everything comes up normal and holds there. It results in the contraction of the puborectalis, which increases its traction on the anorectal junction, returning the angle to its basal state. I'll be explaining a lot more into this in more detail. This is just giving you an overview. And then you get the full closing of the anal canal. So as you can see from these 4 phases, it's quite a complicated process. So when you're looking at potty training a child, it's kind of like, I just want my child to poo in the toilet. And that part seems quite simple, but the actual bodily function that needs to occur can be quite complicated and can be quite stressful for a child, especially if they have sensory issues, maybe they have special needs, maybe they're just a highly anxious child. There's a lot going on in their little body that they're suddenly feeling that can be quite stressful for the child. So for the child, they get that internal sphincter relaxing, they gain awareness, whether it's gas, solid, or liquid, and then they have the choice of going to the toilet or waiting. So if they choose not to go to the toilet, then their pelvic floor and that external anal sphincter contract, and they're not going to poo. But if they decide that they want to go to the toilet, then they first have to find a toilet that's close by. Mostly if they're younger, telling mom they need to go to the toilet, and it's a mad rush to suddenly find a toilet, make sure everything is perfect in order for this child to go to the toilet. They then have to get into the correct position. So of course, especially if you're in a public toilet, the toilets are quite high, it's quite hard, the child's nearly falling in the toilet. There's a lot of things that go in that play into this. Once they get into the correct position that they need to relax that pelvic floor, the increase in that interrectal pressure by pushing until they feel that they've emptied out. And then once they finish, that pressure decreases and everything kind of goes back to normal, and the anal canal closes and the child wipes, dresses, and flushes. So it's quite a process for them to complete this complete, emptying process. And it can be, as I said, quite stressful. So for the child, one of the things that I wanted to speak about is this rectal anal inhibiting reflex. And this is the reflex that is a sampling mechanism. So it's when they having that feeling that they need to go to the toilet in their bum, it's that involuntary relaxation of that anal sphincter in response to that distension of a rectum. So basically it just means that there's a poo that needs to come out and they're getting that feeling. And this allows the upper anal canal to tell them, is it gas or is it poo? So that they can know what they need to do with it. If they decide to delay, that anal sphincter regains its tone by the external anal sphincter contracting and the feces moves back into the rectum. When it fails is when there's diarrhea or bypass diarrhea, and children who are very constipated or have a mega rectum, which I will explain later, the body is trying to get rid of that excess feces. This inhibiting reflex doesn't work, and they often can have a leak. So that's a leak of normally poo coming out. You'll feel that's normally when you're seeing those skid marks or a little bit of like runny poo coming out into their either their nappy or their pants. You'll get that that leak. For a child, how many times they're going to the toilet will decrease with age and should be similar to an adult by 4 years old. It's normally 4 to 9 bowel movements per week, which is from Pilat, but the person that we'll be referencing quite a lot is Dr. Hodges. I'll give you his website at the end, and he says a child should definitely be going to the toilet daily. So in order to go to the toilet, what things do we require? We need that physical ability to get to the toilet, undress as well as redress when complete. So a child should be able to take off their pants, and underwear and put it all back on. They need to be able to, of course, walk there. They need to be able to climb up to the toilet if they need, or be able to get down if they're sitting on a potty. They also need a cognitive ability to sense and act on that urge. They need to know that, you know, I'm feeling this. What does this mean? And what am I going to do with it? They also need all these different parts of their pelvic floor and pelvic system to be working. So that's your internal and external anal sphincter. They need colonic transit to happen. That's going through the large intestine. They need a puborectalis muscle and anorectal reflex. So when we talk about your pelvic floor, it's bowl-shaped. Sorry. And it basically holds all these internal organs up. It's attached to the pubic bone in the front and the tailbone at the back, and then on the sides by the pelvic walls. It helps with keeping continence. It allows emptying. It supports all the organs, sexual pleasure and functions, and it's an important part of the core. Any ladies who have given birth will know often we recommend going to see a pelvic health physio, because with the stretching of the tummy and everything, you often find that sorry, your pelvic floor can be quite weakened and normally would need some muscle strengthening. Same thing can happen with our child if they are holding onto their poos. So this can stretch and lead to problems with their pelvic floor.
This is my first time.
Okay, what happens to the
Thought I'd
pelvic?
escaped it.
Sorry, what happens to the pelvic floor when constipated?
They're new. It's new.
So hypertonic in children who have suffered with chronic constipation due to continually contracting against that full rectum, it's overactive and therefore I'm so sorry, overactive and therefore harder to relax fully to empty the bowels. There's a reduced movement of it because it's continuously contracting for the kids that have constipation. And then it's also the discoordinated defecation. Sorry. Constipation. I'm so sorry. Obviously from talking, I've got a tickle in my throat. So constipation actually affects between 10 and 20% of children. Its peak incidence is between 2 and 4 years. So obviously this is when the potty training starts. And the functional constipation is where there's no reason for them to be constipated. There's no medical abnormality. There's nothing wrong with their structures. It's just that they're getting constipated. And this constipation is 95% of constipation cases. And this is why I'm doing this presentation, and hopefully we'll be able to help a lot of you if your children suffer from constipation. If they don't have this functional constipation, it can also be due to different diseases, malformations, diseases, etc. But majority of their childhood constipation is functional constipation. I do have a video that I am going to play for you to hopefully show you more of what I'm talking about.
The purpose of this video is to explain why soiling accidents occur and to help you understand what you can do to stop them from happening. Poo accidents can be embarrassing. Many children who have accidents can't tell when they're coming, and they're not able to stop them from happening. However, it doesn't always have to be this way. When we eat food, it travels from the mouth, down the throat, and into the stomach. In the stomach, the body begins to break intestine. Sometimes the large intestine is called the colon.
Sorry, everyone. I will just rewind a little bit and carry on playing. Sorry about that.
Enters the small intestine. The small intestine is a long, twisted tube where nutrients are absorbed into the body. The body uses these nutrients to help you grow and gives you energy to do all the things you like play, run, sing, or whatever you're interested in. The unneeded and unabsorbed liquid becomes poo and travels into the large intestine. Sometimes the large intestine is called the colon. When the poo enters the large intestine, it is liquid. As it travels through the colon, water is absorbed back into the body and the poo becomes more solid. The poo eventually comes to the end of the colon, also known as the rectum. At the very bottom of the rectum is a band of muscle called the anal sphincter. When the poo puts pressure on this muscle, a message is sent to the brain saying it's time to poop. The person then decides if they are going to use the bathroom now or hold it to go later. If the person decides to go, the anal sphincter relaxes and the poo comes out. Problems occur when the person decides to hold it and not go to the bathroom. As the poo sits in the rectum, water continues to be absorbed by the colon and the stools become harder and harder. And as more food is digested, more poo continues to come into the rectum. The rectum grows bigger and bigger, and if this keeps happening, the poo begins to back up into the colon. Eventually, the person finally goes to the bathroom and the poo is very large and hard. What's worse is that it will hurt to poo. This is called constipation. The rectum is like a balloon. The first time it's blown up, it returns back to its original shape and size. However, if it's repeatedly blown up, it eventually becomes big, flabby, and weak. This stretched out rectum becomes a large holding area for poo, setting up the process to repeat itself. And with an overstretched rectum, some children lose the urge to poop. The body then gets sneaky. Remember, when poo first enters the colon, it is liquid. When the new liquid poo meets with the old hard poo, the liquid poo slides through the hard poo and comes out as smears in the underwear. This cannot be controlled and usually is not even felt. Others can tell this has happened by the smell, but children having poo problems many times don't even smell this. The good news is that it doesn't have to be this way. You can stop your body from having accidents with just a few easy steps. The most important thing to do is to sit on the toilet every day and try to have a poop. The best time to sit on the toilet is after eating. Our bodies have a special reflex. When we eat, our stomachs tell our colon to make room by letting the stored poop out. So you should sit on the toilet after breakfast, after lunch, and after dinner. The way you sit on the toilet is important too. Your feet should be flat on the floor. If your feet can't reach the floor, a stepping stool will be needed. This will make it easier to push the poo out. Also, you should sit up straight. Some children like to sit forward. When this is done, only some of the poo will come out. Other children stiffen and cross their legs. This tightens the muscles, and again, not all of the poo will come out.
Okay, so I hope that kind of gives you a better explanation of kind of what is going on with system. Where are we? Sorry, there we go. Okay. Okay, so we spoke about that. And then, so now we're talking about this functional constipation, and then I hope that video kind of helped explain to you how constipation can occur. So it's associated with lower urinary tract symptoms. So often especially your girls will often get continuous UTIs because of this stretching and pressure on their bladder, and also leakage. It can cause UTIs, and fecal incontinence 2.9%. The causes is multifactorial, not always understood, and it can be different reasons for different children. They can, withhold due to a previous painful experience. It can be because they've changed their routine. It can be because there was no toilet available, or they at least didn't think there was a toilet available. It can be because of illness. Those kids that are changing schools, I know often like a school, requires that a child should be fully continent before they attend school. And suddenly there's this whole stress, they're changing school, now they're out of nappies, etc. It can be toilet access rules. So often, in class, a teacher gets irritated with every single child maybe asking to go to the toilet, and often they suddenly get that urge, but they might have gone for a wee, not too long ago, and therefore not be allowed to go again. And there is some sort of genetic link. So maybe if you were constipated as a child or had toileting issues, there might be more chance for your child to also have constipation because of that. So how functional constipation is caused. So the child gets dehydrated or delays defecation because of change in routine, school, or caregiver. So that poo stays in that rectum for a longer period of time. The fluid gets reabsorbed into the body, and the poo stays there and gets harder. When the child decides that they actually, they're home, they're in their nice environment, and they're going to poo, they're getting a little bit of that feeling, that poo is hard, it hurts, and can even cause anal fissures. So if your child has ever gone to the toilet and you've wiped them and there's a little bit of blood, or it can be really painful, even just that, and they might say, no, mommy, it hurts really, like I can't go to the toilet, it hurts too much. So the next time they go, they remember that previous unpleasant experience, and they decide they'd rather hold it in, not thinking that that's what happened last time and that's why it was sore. So that still keeps piling up into that rectum, which becomes bigger. That rectal diameter increases and results in decreased sensation. So basically, if you think about it, you've got the sensitive organ. When it's stretched, those nerve endings and sensations are now larger, and therefore it's not as sensitive. So they'll lose that urge to defecate, and it just causes the cycle to continue, which makes the problem worse and worse and worse. So the criteria for functional constipation is 2 or more of the following occurring at least once per week for a minimum of 1 month, with insufficient criteria for a diagnosis of IBS. So they're having 2 or less poos in the toilet per week, of a child of at least 4 years, 1 episode of incontinence per week, history of retentive posture or excessive stool retention, history of painful or hard bowel movements, presence of a large fecal mass in the rectum, which can be seen via scans, and history of large diameter stools that can obstruct the toilet. So, and if there's no other medical explanation for it. So megarectum is a dilated rectum due to stool pileup. The rectum goes from a sensory organ to a storage organ. So we're wanting it to be that sensory organ, for them to sense that it's full and they need to go to the toilet, not to store the poo. The rectum becomes stretched and therefore loses its tone, as they spoke about the balloon and losing its tone, and they can't pump that stool out. And then after that, of course, because it's a large organ, they're needing those large poos to come so that they can start feeling. And also it's floppy and they're losing that sense. So functional constipation can be associated with reduced quality of life, can affect academic performance because if your tummy's sore or you're too worried about going to the toilet or anything to do with that, you're not going to concentrate in school. It can also cause aggression, anxiety, depression, and increased emotional reactivity. Because if you need to go to the toilet or you're constipated and someone does something, it can really irritate you. You've got that decreased frustration tolerance. Symptoms of functional constipation can even persist into adulthood, even if they're using laxative treatment for 25% of children. There's poor clinical outcomes at adult age. If there's an older age of onset, longer delay between them having constipation and coming to seek help, and lower defecation frequency. So contributing factors, we spoke about the genetic predisposition, a low socioeconomic status, obviously access to things needed for going to the toilets, their dietary and fluid intake have a huge impact on it. And also if they're immobile, so if you have a child with special needs or a person that is wheelchair bound, or any sort of, if the child's too young and you're potty training them, they are immobile, and if they have that withholding behavior. So they start with this withholding behavior, they have this like basically discoordinated movement of the poo and things going wrong, which means incomplete evacuation of the poo, which can impact the poo in that rectum, and then you get that overflow incontinence when that fluid poo comes through. So to diagnose functional constipation, you can use lab testing, you can go for an abdominal x-ray. It has been known to be controversial because you're giving that radiation exposure to a child. So what the new kind of finding shows that you'd rather measure that transverse rectal diameter, because obviously with that megarectum or that storage of poo, even if there's no poo currently in that rectum, you'll see that that diameter has increased. So anything over 3 centimeters indicates constipation in children. So for everyone on this, these are some signs to look out for that could indicate that your child or a child in your class could have constipation, or even a child that you know. So poos that look like rabbit droppings or balls, very wide poos, you know, that fill the whole nappy, fill the whole toilet, can cause blockage. Very loose poo, because obviously that's poo sliding through. Any poo accidents, skid marks, itchy bum, using too much toilet paper, needing to push really hard when they're on the toilet, not enough poo coming out, too many little poos, them constantly complaining of tummy aches, bedwetting and accidents, because obviously when they're all relaxed at night, it can put pressure on the bladder. I am going to do a further presentation on bedwetting, as well as incontinence. So wee accidents during the day, that'll be coming up soon. If they're having any problems with toilet training, especially for girls having recurrent UTIs, or if they're having lots of wees close together, these are signs that there might be something going wrong. And I would highly recommend you go see your ped, or even, and hopefully your ped, you know, can maybe refer and come see me and see how we can help. This is a nice visual that we can show the kids for them to, because of course you're not with them on a daily basis, and you don't get to be in the toilet with them, especially at school. So therefore they can be able to tell you a bit better what's happening at school. You know, is it healthy poo, or is it bad, like not bad poo, but is it like not healthy poo? So it's just a nice visual that is on Dr. Hodges' website, which will the resource will be given to you at the end. So how do we treat this? So the biggest thing is identifying it, because a lot of parents, even lately that I've spoken to, they're like, no, my child has no issues. They go like 4 times a day. And I'm like, that actually can mean that there are issues, because there's not that proper emptying happening, or is it just sliding past and there's actually poo stuck there? So this identification that there could actually be something wrong, you know, what are the signs? Is there something going on, and doing something about it? Education is key. So, you know, that explanation for a child, for them to understand what's going on with their body and why is it so important that they're not holding on, and how it will affect them. So there is insufficient evidence to recommend probiotics as treatments, and also little evidence to support the administration of fiber supplements if they're already having a normal fiber intake. So increasing that fiber might not help, but if they are, of course, not having enough fiber, a good fiber high diet is recommended. We look at disimpactation, so that's starting to look at laxatives, suppositories, etc., which I'll talk about in a bit, and then maintenance therapy, so beginning to wean those laxatives. So there's a whole bunch of laxatives that we could use for treatment that your ped can discuss further with you, but what you're basically wanting to do is empty out. So Dr. Hodges recommends a daily enema and softeners for 30 days, and then kind of moving on to weaning that off. So the purpose of this is to completely empty that rectum to allow that, floppy rectum to kind of regain tone and come back again, so that that can be a sensory organ, not a storage organ. From a parent's perspective, it has been said that children don't mind the enemas because they're quick and over with. And patients who underwent the enema program had significantly greater changes in rectal diameters. You can use glycerine suppositories instead of enemas if needed. And it's just important that as parents, you're comfortable with it. Anyone that had the cleanouts, their treatment success corresponded to how aggressively the child was treated, because often we can shy away and go, like that's, medication, enemas and stuff can sound quite scary. But the children who had cleaned out followed by the daily laxatives were more likely to respond to treatment and also have that long-term success. So even after 2 months of treatment, a child might remain symptomatic. So the child needs to get to the point of that stool being watery with tiny bits of stool to indicate a proper clean out, and therefore being able to help them from there regain that tone of the rectum and make sure no further problems occur. We look at lifestyle changes. So, getting them to understand their anatomy, how the body works, drinking enough water, eating a high fiber diet where possible. We look at how they're sitting on the toilet, what is their position like, teaching breathing exercises, also some good yoga movements, get that relaxation, understanding that body awareness occurring. And also, of course, as OTs, we work in their functional, what exercises can we do, get that body awareness improved, and also look at that core strengthening. So this is just an example of kind of a table that I might use with the clients to kind of indicate with them, are they ticking all the boxes? Are they drinking enough water? Are they eating the fruit and veg? Have they sat on the toilets? What does their poo look like? You can include, of course, the laxatives and other medication they might be on from the ped. Have they done their breathing exercises? How many wees have they done today? And was the bed wet or dry? With a younger child, the parent would probably fill this in for me. With an older child, we've looked at cases through this course of children who are 13 that are still wetting themselves, and just being able to help those children in order for it not to affect their social lives and also their school life, and for them to lead a normal life. So my role in treatment is to support toilet training. So I would work the balance, core stability, how is that body relaxing, and also putting less pressure on the child to gain that toilet training. I'll talk about it in a little bit now. Educating parents and the child, increasing awareness of their sensations. So as OTs, we're working a lot with sensory integration. So looking at their sensory profile, seeing if there's anything affecting the child and their ability to go to the toilet. Do they not enjoy their sensation of when the poo falls, the water splashes their bum? Is the toilet seat too cold? Is it too hard? So looking at those kind of aspects and seeing if there's anything else affecting the child and their willingness to go to the toilet. More physio would work with the pelvic floor training, but also as an OT, just making sure that we're all in this together. So discussing with the pediatrician involved to make sure that we're all working together for the benefit of the client. So just to give you an idea of kind of what sessions would look like if a child had to come to me for treatment. So I would do an examination, just with clothes on, just to see what's going on, giving them kind of the education similar to what I've done today, but way more child friendly. I've got some cool new games that can make it less taboo to talk about. Lots of pictures for my room to make them a little bit more comfortable when they come to see me. Talk about what could irritate their bladder, what could cause constipation, looking at how they're sitting on the toilet. Maybe we look at introducing a stool to help with their position or how their toilet looks. There's tummy massage that you can teach that can help the child, and also they can do it themselves if they are that little bit older. And breathing techniques. So If any of you have seen a pelvic floor physio or come for breathing exercises, it's the like moo breathing, there's the bee buzzing breathing. So very child-friendly breathing activities that they can try on the toilet in order to relax and get that movement. Looking at that chart that I just explained to you, that table, and just getting them to fill that in, and then often requesting those stool softeners from the doctor. Session 2 will be more an update, asking the mum, how's it going? What are they finding easy or hard? Reviewing that chart, recapping any education, maybe re-looking at that tummy massage. So these 2 sessions would mostly be face-to-face, but thereafter we can do teletherapy as follow-ups. So the topic that all parents love talking about, just to give you some tips to leave here with regarding toilet training and the new kind of research that's come out. So they recommend toilet training only after 2 years. Because of that cognitive understanding, that ability to undress, dress, that mobility, and that, just that whole understanding of what's going on. And they recommend it to be done by the age of 3. So that's dysfunctional weeing or incontinence is due to late toilet training and can also be associated with constipation. Children trained before the age of 2 had triple the risk of developing constipation and daytime incontinence compared to those trained between the ages of 2 and 3. So closer to the age of 3 is more preferable. If a child has medical comorbidities as Down syndrome, autism, cerebral palsy, it reduces the likelihood of successful toilet training, and often they'll need to come to us OTs to kind of work with the parents. We work with pediatricians and other specialists. Complications of toilet training include stool toileting refusal, withholding those poos, hiding to poo, incontinence, etc. So rules for potty training: watch closely for any signs of constipation is there, and don't even start trying to train the child until they're pooping mush every single day for months. So you don't want any sort of constipation occurring before you start, and get the school to send reports home if possible of how many times they've gone to poo and what did it look like. Wait until your child is ready to potty train, not when you or your preschool are ready. So what I've found, just starting with this at KidsAbility, is that a lot of parents tell me that the summer before the child started school, they rushed to get their child potty trained. And it can be that you've rushed them into this, and often there are issues that occur because of this. So you're wanting the child to be physically, mentally, emotionally ready for this process, as well as you as parents, that you've got the time to sit with them and understand and make sure they are doing everything correctly to get it right from the beginning, so that there's no problems that occur later. Your child should be able to dress and undress, show interest in using the toilet, go to the toilet in front of them, get them to understand what happens on the toilet. Why do we do what we do? What is it called? What does it sound like? Make it less taboo to kind of talk about and have in front of them. They need to start noticing when they have a dirty diaper. So when they've done a poo, be like, "Mummy, poo, nappy, need change," or something simple like that, that they start to understand. And also preempting when they start getting that feeling that they need to poo or pee, and be able to go onto the potty. So let your child lead the way, no punishments or disappointments. Use the toilet when your body tells you, rather than it's important that you don't wee or poo, or that you don't soil your clothing. So open door policy, as I said, I've got the feeling that I need to wee, so I went right away, and showing them that this is what your body does. And even though their body is like smaller than yours, it also works in the same way. Explain why it's important to poo daily and pee often, and that everyone poos and that it's completely normal. You know, if one of their friend is potty training at the same time, be like, you know, hey, this person's also doing this because it's normal. Help them to recognize and act on that urge to pee and poo. So you don't want to do any of those voiding behaviors of a boy like grabbing their crotch, even a girl, squirming, squeezing legs together, anything that they can do. As soon as you see those behaviors, making them aware of probably why they're doing that and, you know, trying to avoid those. Point out where the toilet is when you're going to the shops. So say you're going for a day at Kamado Bay and you're trying to toilet train the child. As you go walking past, be like, oh, there's a toilet right here. We're right over here, but look, there's a toilet right there. So they know, they're comfortable, and they know when they need to go, they can go easily. Kids who only poop at home are more likely to withhold. So make it the norm from the get-go. Carry a foldable toilet with you. So you get those potty seats and you can just take it with you, or keep a potty in the car. Prompt them to pee every 2 hours and try and poo after breakfast and dinner. So sitting down with a book, relaxing, getting them just to sit straight after eating. Watch for that wee holding. You need to empty 2 to 3 hours for healthy bladder growth. We don't want them holding on. Establish a PCH schedule that fits easily into the day, first and last thing, and then every 2 hours in between. None of that potty dance, that withholding, that clenching. Say it's time to go to the toilet, not do you need the toilet? Because of course, if they're playing with something that really interests them, they're going to say no. Get them to relax on the toilet and let it all out. No red face, no straining, just relaxing. As I said, books, puzzles, egg timers were great in order to get them to sit for a good period of time that they're able to fully empty. Important, boys need to learn to sit on the loo for weeing. Obviously, when they're older, they're going to enjoy standing and all the fun things that boys get to do. But when they are learning how to wee, they need to sit on the loo, because how this affects their pelvic floor and their ability to relax, which can affect their poo, and therefore their constipation can occur. So you want them sitting in order to relax, understanding that position and learning how to do it when they're older, or even, I mean, now and again, if they're playing in the garden, I understand, but trying to get them to sit on that potty. Girls must have legs apart. It relaxes that pelvic floor and stops that urine pooling in the vagina and staying wet, which can cause a UTI. And also never shame and blame for accidents. If they're still having accidents after a month, they probably weren't ready, or they need to see if there's constipation that's occurring because of this toilet training. And don't ever stop asking your children how often they poo. Keep tabs throughout school, even if they are at the age of 8, you know, any time, especially if they like, you know, going between schools, or if there's been something, you know, maybe there's divorce happening at home, if there is, even with coronavirus, you know, if there's been like highly emotional things, just check in with them, make sure everything's going fine, because, you know, schools, I don't blame them. They're so busy. It's not enough time to always report to us, but always making sure that they are telling you how it's going, and always provide a high stool to support their feet for correct positioning. The things that often go wrong, wees are usually easiest to master. A child will do that much easier. So the child ends up doing a poo in a nappy when on, or for a nap, or at night when they have that nappy on again, or they withhold. So a child becomes a nappy only pooper and then starts to fear or avoid this potty or toilet for pooing. So you're wanting to make sure that they're comfortable with that pooing on the toilets. Boys who only stand to wee and also stand to poop, it's more difficult to transition from that nappy to the toilet. So even if your child isn't toilet training and is in a nappy, get them to squat down and try to do it in their nappy in a squatting position rather. Nappy poopers are very, very common. If a child is not ready or not getting it after 7 to 14 days, was lost interest and parents push on, rather go to back to nappies for a bit if the child isn't ready. One of the big problems is the potty training is rushed because the child is required to be out of nappies because of beginning of school. And this is something that they're starting to look at worldwide, at saying, you know, why does a child need to be continent to enter school at the age of, you know, 3, 4, and looking at it and how important is it just to take away this kind of rush for potty training to happen. So some useful links for you: that Poo and You video that we watched. Bedwetting and Accidents is Dr. Hodges' website. There's some lovely infographics that you can get and information. There's some information for pelvic floor anatomy, and then another website. Another a really funny, cute app to get is Poo Goes Home to Poo Land. It's a little story about a boy who feels like he needs to poo and the poo wants to go back to Poo Land. There's weird and wonderful things that you can get to help make it less taboo for your kids to understand. These are just some of my references. And yeah, I just want to know, does anyone have any questions?
Hello.
Hi.
Hi. Yeah, I have a question, because you talk a lot about, well, you don't talk a lot about it, but fiber is very important to the little ones.
Yes.
So how do you encourage the, eating of fiber, or what would you give if there was a fiber supplement, like if was needed, like a Metamucil kind of thing, I guess?
Yeah, so what I've done is, of course, I'm an occupational therapist, and I understand that they, of course, are other professions more educated in this topic. So we do have, dietitians on the island, which I would refer to.
Okay.
I can do very simple, soluble, insoluble fiber, and just look at the fiber intake and see if I can just, give some education and just a brief, give brief help with regards to their fiber intake. But if there are further issues, or if the child's refusing for any other reason than sensory or anything like that, I would get the dietitian involved.
Okay, great. Thank you.
Pleasure. I see that Courtney has asked a question on the chat about the floppy rectum becoming, regaining that tone. Yes, it can regain that tone, and that's why we do the full emptying with the laxatives and suppositories to make sure that we're not stretching it anymore. And just like when a person kind of, maybe puts on some weight and gets back, we can get that muscle regaining its tone and sensation. And she also asked what imaging is used to see that rectal diameter. You use an ultrasound machine. So this is where either a physio would do it, or you can be sent with your pediatrician for an ultrasound to check that rectal diameter. I hope those answer your questions. Oh, thanks so much, Shala. Sorry, I'm just going through the questions. For all that you know, Kaylee Lahner is a dietitian, and if you look on the chat, she has answered the question about our fiber intake. So Courtney also just asked a question on tips for motivating a child to attend to signals to poop versus withhold. So you would need to find out, first of all, if they are feeling it in their bum or in their tummy, because often if you tell the child, if they're feeling it in their bum, they need to go to the toilet, and the child's like, well, I never feel that, so why do I need to go to the toilet? But maybe if you mention, if there are constipation issues, mention to them that, maybe you're feeling it in your tummy, and that could be because of the constipation and the decreased sensation. And maybe explain to them, how you feel when you need to go to the toilet, and what steps do you take in order to go to the toilet, to make it a little bit more relatable for them. I don't know if that helps, Courtney. I mean, we do, coming to me, would have to look at their sensory system and just make sure there's nothing impacting on that as well. Are there any other questions? Okay, so Caro asked a question, sorry, I hope I pronounced your name correctly, on rewards for pooping when constipated. So a child that is either pooping only in a nappy or isn't pooping, it is completely fine to reward the child when they sit and go to the toilet on the recommended timing. How you do that is completely up to you. Some of the tips and tricks that I've been using with my child who's currently potty training is using just a small little sweet every single time he sits on the toilet and does a poo. At the moment it's wheeze as well, but if it's just for poos, rewarding them for sitting on their toilets, defecating effectively and at the correct time. Rewarding is great. Courtney, can you review again how long that took? Courtney, sorry, I hope I'm understanding. Are you wanting me to go back to the slideshow and chat more about laxatives and the period of weaning off, or how that weaning off period occurs? Okay, so with laxatives, it is more to do with your pediatrician. There are a few different protocols that different pediatricians will use, but basically it's over normally a 3-month period that the child goes from daily laxatives and suppositories until they are getting that full empty out, and then they start to wean off. Normally it'll go to every 2 days that they'll start using. The weaning process is quite different for every single child depending on how they respond to treatment, because of course you're not going to move them onto less if they're not getting that full empty. And then period of weaning off. So when they're weaning off, you're wanting to make sure that you're looking for all those signs. Are they going back to pushing too hard? Are they going back to withholding? Are they going back to any of those behaviors that started in the first place? So making sure that none of those are occurring, that is going to cause constipation to return again. There's a few more minutes. Are there any other questions before we close off? Okay, I'm going to stop the recording. Thank you everyone for attending. I really appreciate it. And I hope you've learned something through today. If you are needing any assistance, then please contact your pediatrician. They should be able to refer to me in order to come as an OT and be able to look at the things that I spoke about. But yes, if you have any further questions, please contact me, and yeah, I look forward to maybe seeing some of you, or we can do further presentations on potty training, and then also talking about that incontinence and bedwetting. Thanks so much and have a lovely day further. Bye.